Cordial saludo, mi nombre es Juan Esteban Gómez, jefe del Servicio de Cardiología de la Fundación CARDIOLILI, y yo los acompañaré en la moderación del Simposio de Falla Cardiaca. Desde las 2 hasta las 5 de la tarde disfrutaremos de conferencias de muy alto nivel dictadas por expertos internacionales. Ellos son el doctor Héctor Ventura de Estados Unidos, Nicolás Manito de España, Gerásimo Filipatos de Grecia, Viken Boscourt de Estados Unidos, Mandip Mehra de Estados Unidos y John McMurray del Reino Unido. Al final de cada uno de los bloques de este simposio tendremos un espacio de preguntas que podrán ser resueltas en tiempo real. Los invitamos a que ustedes las vayan haciendo en el chat del evento. A continuación, damos inicio a este simposio. Bienvenidos. Nos vemos. Buenas tardes.
Good afternoon, everyone. We are just beginning the second phase of academic activities for today. Here in this room, we have very important people with experts, with world leaders, and the most important, with colleagues and friends at the same time. The symposium of heart failure, we will have the participation of the Dr. Héctor Ventura from New Orleans, Nicolás Manito from Barcelona, and Gerasmo Filipatos from Greece. The Dr. Ventura is in New Orleans right now. He's also a colleague, and he's my mentor as well. He's going to be talking about heart failures with fraction ejections, leg ventricle fraction ejection, so he will be able to tell you about. So welcome, doctor. Okay, thank you very much, and thank you to the Cali Colombian, to the Foundation for this invitation. Well, I don't know how I'm going to deal with this subject. It's kind of difficult, but well, we'll see if in 20 minutes I will be able to say what I have to say. Well, this is the title. I'm going to try to change the titles, and I'm going to say that the elusive handling of the heart failure with fraction ejection is a little bit what I'm going to talk. Well, what is my opinion in regards to the heart failure? So, well, we have Johnny Depp right here in the Pirates movies, and he say, I pretty much try to stay in the constant state of confusion just because of the expression it leaves on my face. So what he says is essential in the state of confusion. So the subject is a very confusing subject because there are many things and there are few things that everybody will agree. So we have the definitions. So we have a patient with heart failure with a preserved ejection fraction over 50%. And also we have a clinical definitions, and I'm going to talk a little bit more, to which are some patients that they have as diverse syndrome initiated by a variety of comorbidities and inflammatory mediators with extra cardiac manifestations and some others cardiac abnormalities. Epidemiology, well, most of you know this, it depends. Generally is well known in women, and the factors of the comorbidity are obesity, diabetes, and atrial fibrillations as well. So this is a study that was done many years ago, but it stays the same for now. The fraction ejection compared with the reduced in this case. Well, nowadays, we talk moreover about this subject. There are some things happening to these patients. Obviously, we selected the comorbidities, renal insufficiencies, and the systemic inflammatory, and these mediator factors are augmented in this patient. There is pulmonary hypertension. There is also hypertrophy. And there are abnormalities in the exercise muscular. And you can actually see that The endothelium cardiomyocytes signaling, they show some problems, and it's something systemic, as I said before. It's more than the cardiac part. So let's explore this part. So what happened with this disease of the fraction of ejections in the different studies or that have been done, the presence of hypertrophy, ventricular left ventricular is this percentage with hypertrophic left ventricular. So the definitions in this case has to do with what's the meaning. Well, what is the meaning for this? For example, this is a study that was done in Brazil in an autopsy that everybody can see that 1, 2, 3, 4 depends on how much hypertrophy, and has to do with the myocyte diameter. But the most interesting is that the muscle is not only augmented, but there is more fibrosis as well. So more hypertrophy, more fibrosis. That also has to do with the fractions ejection preserve. So what's happened with the left auricle? So what is the dilatations in the studies, in the clinical studies? So it's very high, 60 to 80%. The auricular fibration is the diameter, augmented diameter is very big, and the people have brilliant. They show that, for example, the highest the ventricular mass, the highest the left auricular volume. So it shows what I was saying before. It's a systemic disease. So, well, yeah, this is a very good study from that it was published 11 years ago, where they show that the patients that have fraction ejections preserved, they have more prevalence in pulmonary hypertension, but not also more with the hypertension. They have more prevalence. The mortality is way too high. It's higher. The pressure is more than 48 systolic. So this is another target that there is exists in the disease. And this is actually new. In Malay, the fibrosis, that would be the extra volume cellular, the highest, the mortality, but the mortality is higher. So, for example, so the one that has the surveillance is less. So there is a certain amount that it also depends of the extracellular mass. As you could see, between 30-35%, the survival is fewer. So the magnetic resonance also is very important to see what is the fibrosis present in these patients, and is the way to see it from the medical standpoint. Well, for the definition, there are some scores. For example, this is the score that is called H2FPEF, obesity, pulmonary hypertension, elders, and feeling pressure. So this is a score that goes from 0 to 9, and the lower is the highest the possibility, or the higher, well, the bigger. So it's been studied in circulation, and there's been some other studies that it's about to be related with this score. So we will see what happens in the future. So what is the management? The physiopathologic targets in this case would be the diastolic dysfunctions, the ventricular arterial dissociation. We will have a lot of time, pulmonary hypertensions, chronotropic incompetence as well. So, well, you can see right there the diastolic presence. These are the different studies that have been done, taking into account you can see the diastolic exists in some studies. In all the studies, it could be normal, mild, moderate, and severe. That would be a target. But what about the treatments? The treatment that is still used, that are to reduce, lowering the systemic blood pressure, is very important. There is some calorie restriction and exercise, regression of the left ventricular hypertrophy, avoidance of tachycardia, control of fluid ballots and diuretics, and so on. So this is very interesting. It also shows that in the muscular part is affected in these patients. For example, in the relation between capillarity and to the fiber ratio is lower in this patient with the people with the same age in blue here, and this is related with the reduction of the intolerance to the exercise. So the same will happen with the different types of fibers. Fiber 1, they are less common in the patients that have heart failure with fraction ejection preserved, with preserved fraction ejection. And the most important, that we can analyze the exercise if there is heat resection. You can see how the patient could improve. So the exercise and the heat in the obesity is very important in these patients for the part of the treatment. Well, take a look in here. These are some animals, obviously, but the fibrosis is reduced with the inhibitors compared with the antagonists of calcium. So we said that this is very important. It's a study that was done in animals, but it shows the disparity. And this is in human beings where the inhibitor was done before the treatment. You can see this all red, it means fibrosis, and 1 year later that it's much more normalized. So this medicine is very important for the treatment. And to improve the systolic pressure is very important. To the relaxation improves when the systolic pressure is reduced under 22 or from 10 to 21. So this would be from Regan as well. It's an inhibitor of the receptors. So what are the clinical trials? Well, I don't have so much time because I only have 20 minutes, but I just wanted that we all agree that the TOTCA has shown that in this part of the world is really meaningful for the probability of mortality. For the interaction of the patients in the rest of the world, it seems not to be like that. There are many reasons for justifying this, but we don't have enough time for talking about that subject specifically. So, well, it always happens, it seems, that there are some studies that are very similar with these kind of problems or issues. So these are the problems that, well, are published. They are very good, but if I'm living here as well, I can see those. So this is a very interesting study. This is very small. Beetroot juice. So in this patient, there are few patients, but this is very interesting. This was published in the journal. It is associate director. I am right there, and it received a lot of attention. And well, you can see that the beetroot juice is very good, actually, and it actually improves. It increased the plasma. I knew that the athletes use this for having a better endurance, and many people like to use it because it also improves the time for the exercise. And also, if you have a doses or if you give it 1 per day, it is very, very small. So I don't know if I should show it in there, but it's very interesting to show, in my opinion. And just like everybody talking about this, so well, this is a study that the Paragon is a study that it's been done. It's going to be right there, so you can ask to Jones because, well, they have done an incredible study with this. The Paragon study for me is very good. This is with cognitive result. And what they show right there is that there is a reduction of the events, not so meaningful in total hospitalizations and CV, cardiovascular death, with the use of the sacubitril. Hospitalizations as well, and cardiovascular death, very meaningful here. And well, something interesting is that we have here ejection fraction between 50 and 57. It's really meaningful, specifically in this level, from 50 to 57, and obviously in an overall, in all the studies, really meaningful. In general, for the final study, the composite is the outcomes. Well, this is a study that was published after the main paragon. This is very interesting. We have the opportunity to read this. Yes, it's published already. So the interesting part is that the more you're hospitalized, if you do not hospitalize, there is no problem. I mean, if hospitalization is very important for improving somehow the incidence rates. So this is important because there is a paraglide study that is the hospitalized patient that is given the medicine to see if this state, if this continue just like that. So you can see right here the reductions. How can I say that? The empty protein B and the valsartan is much better with this valsartan by itself. Well, something very interesting here is, for example, say that Visibasalt shows right here that if you reduce the pressure more compared with the Vasatro alone, the outcomes are not different. So the interesting is that it shows this curve right here, the U curve, in all the cases, as you can see right here. So if the pressure goes down, the mortality is high. So it's very similar right here in all the effects of the outcomes. This is a study that was done afterwards. So we have the opportunity to write down with many two editorials in regards to this. The first one that is heart failure with preserved ejection fractions, separated with the width from the shaft, and this is related with hospitalizations and the importance of an outcome, an esclerotic outcome. And then what is the arterial pressure? And I would like to finish with this. My final comments are the same. So Carl Sagan says, well, not talking about heart failures, but absence of evidence is not the evidence of absence. Obviously, this is a problem. It has, you need to know, I mean, we need to know, and there exists more things that I can remember. Well, in conclusions, in the most common way, it is associated with more significant morbidity and mortality. The clinical trials are neutrals, but maybe Sakuditi Versan is going to change a little bit the future, and maybe the essence of the medicine, the inhibitors will change the treatment a little bit, but the exercise or the weight loss are exercise, and weight loss is important to improve this patient because it's something very bad for this disease. It's associated with the involvement of the pulmonary circulation, right, failures, ventricle failures, and maybe there are some, I mean, these are targets that could be improved the functions of congestion, the lung congestion, and some other things, and maybe the mortality and the mortality of this patient. Thank you very much for your time. I hope to have done it on time. Well, doctor, thank you very much for clarifying or for trying to clarify this very difficult pathology or subgroup of patients with heart failure. Right now, we are going to continue with the new reality of the patients with heart failure. Post-COVID-19, that is another subject, very difficult and complicated subject, but that is your decision. It's up to you. So now we have the Dr. Nicolas Manito from Barcelona. He's the chief of heart failure department in the hospital in Barcelona. So, doctor, you can activate the microphone and welcome. Well, thank you. I'm just activating my presentation. Well, first of all, Thank you to CardioLili and especially to Juan Esteban for the opportunity that has given me for by participating in this and symposiums. And well, yes, right now we are having a very dramatic situation in our professional lives and also in the social level. And in the professional level, and of course, we need to take advantage the hazard moments to turn them into opportunities. I also would like to talk about 10 specific points that could change the reality of the heart failure in this clinical practice. So the first point that we are going to comment is the transition that there is in the presence and the telemedicine and the structure follow-up with patients with heart failure. Another point is that infirmary is key for patients with heart failure, especially in the presential and in the telemedicine. We are experiencing important changes in the managing with some medicines, looking forward to make some synergies. We need to look for the precisions stronger in the for the managing or handling of the comorbidities in the renal cardiorenal syndrome, and we need to face and control the therapeutic inertia. We need to face clinical trajectories in advanced heart failure, and we need to have access to advanced therapies or also telemonitoring by devices. How can we avoid the hospitalizations, the EGLs we're gonna be seeing in the next years, and how the medicine is gonna be changing the precision medicine with machine learning, big data, artificial intelligence. The future is bringing many devices, robotic connectivity, and some other things. Well, COVID effectively is a problem. It's a very serious problem for the patients with heart failure because it affects directly myocarditis, or because it affects indirectly the liberation of cytokines. Is in an inflammatory situation is very important then, or for embolias. Pulmonary embolisms. These persons are going to have a problem, or for patients that have the heart failure. So we need to avoid the patient to go to the hospital. We need to avoid the patient to have the consultation, all the consultation, in this case, the Association of Heart Failure, Spanish, of the Society of Spanish Days and Mesa, saying, we need to leave the patients in their houses. We need to visit the patients for those patients who because the congestion is severe. So we need to do a follow-up by using the telephone. We need to do prognosis or diagnosis very fast in the patients that we have doubts about the prognosis, about COVID or different problems. Therefore, the telemedicine is cleared, is coming by the Scientific Society and the American Heart Failure Society, remembering that the virtual visits are not only for all the studies or states of heart failure, but also for patients with cardiac transplants. And we can see also how can we visit doing telemedicine, obviously using a video in order to see the medication for the patients, in order to see the person, the heart failures symptoms. And this is also an opportunity for the patients in a situation where the emergency or the emergency rooms were collapsing, the hospital were having a lot of problems to access, to receive more patients. But the question is, do we need to have a COVID to understand that there should be a transitional integral for heart failure? Attention, we need to apply models for integrations for heart failure, structure planning models where the continuity in the assistance for the patient is secured, is guaranteed, because we can see that we need to improve the life quality. So this image that is based basically in hospitalization, in a visit, in a structure following, where there is definitions of every single professional that has to participate in this monitoring or in this follow-up. So we need to look alternatives for the hospitalizations, and especially for advanced transitions. So for example, if we talked about hospitals, there is a relation with the family doctors, with the primary attention. And as you could see right here, in infirmary for the follow-up for those patients with telemonitorization or with follow-up by telephone. So the structure follow-up is here to stay, not only because of the COVID. The second point is infirmary or nursery is a key point for patients with heart failure. This study shows how the heart failure nurses can titles, and they can do it like cardiologists as well. So this is a study that was published in Briseño in INGLÉS heart failure, and now the study is going to be published by the Cardiologist magazine that compares heart failure with a cardiologist in a randomized, and they could see the main target of the doses as secondary targets, and corticoids as a secondary, for example, mortality. But in a study of no inferiority, the nurse versus the cardiology, so they were able, you can see that they meaningful, they are not inferior to the cardiologist does. Actually, they can do it very good, and they have the right doses as well. And what is more important, in a very safe way, mortality or CV mortality in a meaningful way, to not to have people come into the hospital in 6 months. So this is a study that complied all the hypothesis criteria and the diseases as well. They were able to reach those bigger doses, the less number of hospitalizations with heart failure, but they also have some visits. The number of visits were higher as well. Well, some changes in the optimization is the third point. So we have medicine very strong. We have mobiles, and we have an intensive treatment, but even though there is a risk, residual risk, there is an important risk. It has to be evaluated in the patients, and to avoid this, the worsening heart failure, that the patient can be taken to advanced risks and obviously to a mortality. So up to date, we have two main goals besides searching for the quadritherapy, and one of those is to be able to do the inverse remodeling. So we need to do the goals in the myocards to try this myocard to be reverted, the function, the ventricular dilatation. So how can we do that? Looking for the medicine that are very strong. So the proof study with some data that we have from shows that the patients could actually improve significant in 12 months the fraction ejection up to 10 points. And the same happened with the index volumes, diastolic and systolic, the auricular volumes, and the ratio E and E. Therefore, what we can do here, this is being translated to the clinical practice, to the daily clinical practice of the ventricular remodelings. The other point is that we have 4 targets, therapeutic targets, that was the block, endosterone, and to activate. We have some medicines for these therapeutic targets, but we have another therapeutic, another target, and it's the SGLT2, because we are going to improve the metabolic, the energetic performance, or yields of the heart, and then we're going to use these medicines. There are some limitations, the fungal infections, or the renal or the volume depreciation. These can be approached by the topic treatments or topic treatment and changes in the medication, for example, the diuretic valorization in these patients. But it's very clear that we have to introduce all these medicines or drugs, and this is the quadritherapy. So this research that is published right here, it says that when we use, for example, the quadritherapy, compared with the traditional therapy, that in this case, IECA and metablock, the results are very strong, as you can see here, the total mortality. But the most important is that when we use quadritherapy in therapy with patients with 55 years old, we have a life expectancy of more than 8 years. If we do it with a patient with 65 years, old, we are adding an amount of years that it could be 6. So the quadritherapy or the quadritherapy has been imposed, will have been introduced even better, and we are going in this direction. Well, the subject about the patients that have been discompensated with heart failure, the hospitalization is an opportunity to change their treatment. So we need to think that these patients could be started versatile thanks to the pioneer study, but evidently it's not an endpoint. We observe a reduction of the PECTF in the patients treated with sacubitril valsartan in a reduction of 39% in the 8-week since randomization. So it's important to remember that thanks to the use of valsartan, we have the rehospitalization. And talking about trajectory check, this is a consensus of the American College in 2019 or 2019, and it shows how important it is to have a trajectory during the hospitalization of the patient, the trajectory at the very beginning when the patient is entering to emergency rooms, when the patient is in cardiology area, knowing what is going to happen with this patient from the clinical projection standpoint, and especially in monitoring or follow-up the vulnerable phase after a month when the patient is discharged. So just like we said in the very beginning, it's important to keep always trajectories in the chronic or in the acute patients. So this is translated into something custom. Another interesting subject is that we have diverse medicine that are acting on the same line, on the same target in physiopathologies, or especially in the case of those substances that improve globally what we are looking for one in a patient with heart failure. We are talking about the stimulation right here. In this case, we have two stimulations. So the one is especially with the Victoria study, and on the other hand, we have the this site that also increase. So finally, this is what it increased the proteins and the AC that favors the reduction of the fibrosis and hypertrophy that facilitates this inflammatory or vascular, but especially a good renal profile in this activation of the. So there is a question that we have to do. There could be a synergy, maybe we don't know, but there is a 15% of the patients that have the renal Victoria, and the Victoria also said that for first time we have a study, heart failure, that will analyze 506 patients, and we have some data that we need to double check. 10% of the patient would be under 30%. So therefore, we have very important information to analyze. The point that we also have to analyze is the patients in this case. In this moment, we have a problem right now, the inertia, therapeutic inertia. But the inertia therapeutic is not only a problem of the patient, it's also a problem of the clinicians. Currently, they say, well, let's not do some changes. Let's see what happened with the situation. Or my patient is doing all right. No, the patient maybe could die or could require a hospitalization. Therefore, the patients, if the doctor does not insist in changing his medication, for example, probably the patient could be in this inertia situation. And sometimes maybe the patient could have a poor performance. So, in the other hand, we have the sanitation system or the sanitary system that sometimes limits the patients to access to the best medicine and to the best devices. Another important point that I want to talk about is the trajectory, the clinic trajectory and heart advancing failure. This is the situation at Spain. Spain is the more stronger country. The donations of organs and the transplants numbers. So it's been reducing at 28% the transplants or transplantation, especially the cardiac transplantation, in a reduction close to 50%, and reduction of donations at 32%. So this also means that we have patients waiting in a waiting list that every time are going to need more mechanical assistance for long term. So We have the Dr. Meta right here and Bustrot, and it has shows that these devices are very powerful, that they have an excellent survival compared with the HeartMate 2, and they have few thrombosis of the device. So we need to talk about, as Donna Mancini said, that effectively maybe is not going to be a cardiac transplantation for patients with advanced heart failure. Maybe we need to set up, or we need to consider that all the patients like potentials, they will have to be implanted with auriculars, mechanical assistance, especially for those patients that are bad candidates for ventricular assistance. For example, the one that have myocardiopathy, or the persons that are not tolerant for anticoagulations, or some other patients that, for example, have aortic insufficiency that could be really complicated to manage during ventricular mechanical assistance. We need to be really precise to protect the renal part. We have two medicines. We have because of this study for diabetic patients, there is this improvements in the less reduction of the medulars, and they modulate very, very good the arteriole, having a better balance of the intermedular. So valsartan has a very good profile, but also we have the ECB2, and especially this study that shows how the fall down of the medular filtration with patients with heart failure, independently if they are diabetic, if they have diabetes or not, and we can see clearly how there is this improvement in the long term, which makes that these are drugs or medicine for renal protections. Valsartan could be a very good option, and in order to avoid the renal insufficiency. So using devices, for example, the invasive devices, we have the guidelines, CardioMate. They recommend it as a monitoring way for the patient, especially what we measure is the systolic pressure. It's the average. That is a device that is implanted in the pulmonary artery, and it stays there forever because it has a battery that does not have any limitation for functionality. And the most important, these are the last information that show how CardioMeds reduce problems for heart failure. We have the total hospitalization, and especially for patients with fractions, intermediate, and preserve. So we are going to have gadgets, an amount of gadgets, many gadgets that are going to help us a lot. They're going to give us a lot of biological data or information of the patients, and we need to be able to integrate this. In this moment in the hospital, we are directing a multicentric study that is the Restage Trial. It uses a platform, the Purine platform, that the patient goes to control by using a mobile device. It's going to have a tension meter, it's going to have a weight, and it's going to have, a survey, a questionnaire of life quality, and also related with symptoms. He's going to be also connected by a computer with the medical team and with nurses as well. This is a patient from our hospital, and he's having a teleconference right now with this nurse. So this also helps us to control the patients, especially for those who have a bad compensation, and we can actually adjust or reduce the possibility of the patient coming to the hospitalization. This is a meta-analysis that shows that not only the invasive or no invasive, it seems that it has a reduction in the mortality and the hospitalization by heart failure. Well, finally, we have new devices. This is the Cordella device that also integrates a detector for the pressure, artery pressure, and it's a system that helps us to see the data, the daily vital signs, symptoms, patient engagement. We can interact with the patients. Those are patients represented by the Wilfred-Millat group. Very good result from the improvement standpoint in the functional capacity, and also, therefore, more devices in order to control the health of the patient. Well, big data is going to change. It's going to change a lot the medicines based on evidence. We have this paper of the cardiology's committee, and they say we have a problem with the clinical trial. So we have to make some changes, and the clinical trials are going to be limited and smaller in this moment. And then we need to have a target in these editorials in 2018. They say why the clinical trials in the future are going to be based on biology and the biomarkers and the big data. Smaller devices, but more powerful. Probably this is the future, that it's going to be the medicine based in precision. And this is a very important information for application of artificial intelligence in the patients they know exactly what is the mechanisms. As you can see right here, this study shows with artificial intelligence if these patients really have an improvement. And it was seen effectively a precision of 95% precision, and they are actually very good. So the future will bring some devices like this one that you are seeing here, mechanical assistant, wireless. These have a better quality, and it's going to be clear that in the future it's going to be like that. And finally, to integrate everything, this is my visions, where we will have always this quadritherapy. And the new reality has got to be applied. It has to be optimized. We need to do clinical pathways, and also we need to adapt the patients depending on the comorbidities. One day, we need to do the right attention for the patients. Thank you very much.
Okay, hello again. We're gonna start the second part of this heart failure symposium. We have here the honor to have Dr. Boscourt, who is the past president of the Heart Failure Society of America and international expert in heart failure. After her participation will be Dr. Mera, who is another international leader. And finally, with Dr. McMurray, we're gonna have the second part of this heart failure symposium with just for you to know that in the chat section, en el chat pueden encontrar el link para traducción.
You can find the link for translation English to Spanish, Spanish, English. So you click on chat, and then in that link deploys all the instructions. So you will be able to do the translation, to receive the translation.
Dr. Boscourt is going to talk about inflammatory cardiomyopathy and viral myocarditis. Doctor, thanks again, and it's for us an honor having you here.
Thank you, Dr. Esteban Gomez. It's a pleasure to present at the CARDIOLILI Symposium. I think my presentation is going to be complementary to Dr. Manito's presentation, and I will finalize my presentation with the need for change post-COVID. I think it's impacting every component of the care, including cardiovascular care. These are my disclosures. And I will first start with the pre-COVID era for us to set the stage about our discussion. In the pre-COVID era, the common infectious etiologies for myocarditis included a variety of pathogens, including viruses such as adenovirus, Coxsackie, enteroviruses, and HIV, but not the simple coronavirus, which caused common cold. And the pathogenesis, as we understood for viral myocarditis in the pre-COVID era, was characterized in three phases. The acute phase of viral entry and activation of the innate immune response, usually within a week. A second phase of activation of acquired immune response with cytokine and chemokine release. And finally, the recovery or the disease progression phase of the virus, and accompanied by sometimes maladaptive fibrosis, remodeling, and cardiomyopathy. The natural history of viral myocarditis in the pre-COVID era was quite unpredictable. In children with acute myocarditis, there were reports of up to 40% of the children developing chronic heart failure and or requiring transplantation at 10 years. 12% of sudden cardiac death in young adults have been reported to be attributable to myocarditis. And mortality rates in biopsy-verified viral myocarditis was reported somewhere around 20 to 40%, or sometimes even up to 56% at 4 years. And of course, those with prolonged QRS, advanced NYHA class, lower EF had worse outcomes. And amongst patients with severe LV dysfunction in the setting of acute myocarditis, half of those patients recovered, quarter had chronic LV dysfunction, and another quarter had severe heart failure requiring cardiac transplantation and or died. There was also evidence of electrical instability in the pre-COVID era. Among patients with active or prior myocarditis, ventricular arrhythmias were reported somewhere in the order of 7 to all the way up to 47% in some series, especially among those with late gadolinium enhancement on MRI. In a 14-year follow-up study of about 1,100 patients who recovered from acute myocarditis, the long-term 14-year hospitalizations were rated somewhere around 6 to 8%, even amongst those who did not require very advanced therapies at the beginning. And the clinical presentations in the pre-COVID era range from acute coronary syndrome-like presentations to new onset heart failure, to arrhythmias, shock, and hemodynamic instability. The diagnosis in the pre-COVID era relied on histologic and immunohistochemical data if a biopsy was obtained, or cardiac MRI findings in which 2 out of the 3 major criteria of edema, hyperemia, and late gadolinium enhancement were supportive of the diagnosis of myocarditis. And if we examine former coronavirus infections and cardiovascular complications, historically, coronaviruses have not been commonly associated with myocardial damage. And in SARS-CoV-1 infected individuals, there was not a large evidence of significant fulminant myocarditis. In one autopsy series, SARS-CoV-1 was PCR amplifiable in about 35% of the hearts, but was not associated with lymphocytic myocarditis, the hallmark of viral myocarditis. And MERS COVID-infected individuals did not reflect fulminant myocarditis, and there was only 1 case report of CMR diagnosed MERS-related COVID myocarditis. And now let's look at the COVID era. The spectrum of acute cardiovascular presentations encompasses a variety of syndromes, which we described as acute COVID-19 cardiovascular syndrome, had a variety of presentations, but the overlapping concept that was probably a common denominator for most of these presentations was an acute inflammatory or injury pattern. And again, the variety of scenarios or phenotypes we saw, but again, we were limited with our existing diagnostic criteria or ICD-10 diagnoses or our former traditional definitions. And these range from acute coronary syndrome to myocarditis to arrhythmias, the thromboembolic complications, and heart failure and cardiogenic shock. But if we were to examine the common denominator for all of these, there appears to be probably a common theme that's causing most of these entities. And this is probably recognized by inflammation and abnormal effects of the inflammation on the myocardial level. And of course, there are possibilities of increased demand and supply-demand mismatch or hypoxia creating an injury pattern, but it appears that the cytokine storm accompanied with vascular injury, and this could be microvascular, endothelial, and all the way to macrovascular injury, appears to be a common theme that we see all across. And as we recognized early on with data from Wuhan, China, there was evidence of myocardial injury in about quarter to third of the patients hospitalized, especially amongst those with pre-existing cardiovascular disease. And of course, this was associated with increased mortality. And the cardiac troponin levels were much higher, along with other biomarkers such as NT-proBNP, among those who were sicker, hemodynamically unstable, or amongst those who died. And the timing of the rise of the cardiac troponin appeared to peak in the hospitalized patients during the time of clinical deterioration requiring ICU admission, intubation, mechanical ventilation, especially during the second week. And those who died had consistent, repeated escalation or rise in the biomarkers, including cardiac troponin, D-dimer, and other pro-inflammatory biomarkers. compared to those who survived. And these created the conceptualization of a hypothetical paradigm of using cardiac troponin as a way to assess risk at the time of presentation, and perhaps serial monitoring with repeated measurements of these biomarkers in patients with COVID for cardiovascular risk assessment. And if we examine what percentage of the patients had evidence of cardiac injury, troponin positivity from the early reports from China ranged from 12% amongst those without cardiovascular disease to 46% amongst non-survivors, and about, as I mentioned before, a quarter of the ICU patients. In comparison, though, when we look at the historical data of non-COVID acute viral infections, historically, the cardiac troponin elevation is about 1% of the infected population. And the range of troponin positivity amongst hospitalized COVID patients are represented on this slide, which is probably a more balanced global representation with the US sites on the right two columns, again, demonstrating a positivity of about 12 to 40% of the hospitalized patients. If we examine cardiac involvement by other means, such as imaging, there are only a few studies that have looked at serial imaging. And this is a study that represents hospitalized patients in a systematic and prospective manner in 100 consecutive COVID patients within 24 hours of admission, demonstrating that echo was abnormal in 68% of all hospitalized patients, 10% showing systolic, 16 diastolic, and about 40% RV dysfunction. And of course, elevated troponin and poor clinical status was associated with abnormal echo and especially RV dysfunction. This is another prospective international survey done by SurveyMonkey, where the investigators collected data from 1,200 patients undergoing echocardiography at the hospital from 69 countries over 6 continents. 60% of the echoes were done in critical care, the remainder in acute care, and 54 patients had acute severe symptoms. 45% had normal echo amongst all these hospitalized patients, and 55% had abnormal echo. LV was abnormal in about 40% and RV abnormal in 33%. Among patients, about 900 patients without baseline cardiovascular disease, about half of those had abnormal echo. Regarding the concerns about sudden cardiac death or cardiac arrest with COVID, we also recognize the adverse trends. In Italy, there was a 58% increase in out-of-hospital cardiac arrest during COVID, and 78% of these were attributable to COVID infection itself. Similarly, in Paris, compared with the previous years, there was a surge in the out-of-hospital cardiac arrest incidence during the COVID surge, with a rapid return to normal after the surge. Of course, these may be related to reduced access access to the emergency system or dying from underlying cardiovascular disease, but certainly raises the concerns for increased cardiac arrest during COVID infection surge times. There are a few studies that examine the long-term effects of COVID-19 after recovery. And you probably have heard about this trial, which gained a lot of attention. Tuntman and colleagues reported that amongst 100 patients who recently recovered from COVID-19, where 67% were treated at home and about a third were hospitalized. After recovery, 78% of the patients had involvement of cardiovascular system by abnormal cardiac MRI. These findings were irrespective of the conditions or severity of the COVID-19, the time of diagnosis or presence of cardiac symptoms, and CMR was performed at approximately 71 days from the onset of disease. At the time of CMR, the troponin I was also positive or abnormal in 71% of the patients and was significantly elevated in 5%. And myocardial inflammation was defined as an abnormal T1 or T2 imaging, and that was present about 60% of the patients. And this was followed by regional scar, pericardial enhancement, low EF, or in large volumes. Study was critiqued for abnormal definition, but still created a lot of concern. In another single-center study of college athletes who recovered from COVID-19, 15% had abnormal cardiac MR findings termed as myocarditis by abnormal T2 imaging and late gadolinium enhancement. And none of these athletes had troponin I elevation, and 2 of the 4 myocarditis cases had shortness of breath. And study was critiqued for not having a control group of what MRI would look like in other athletes. These results raised concerns for the specialists who published expert opinion pieces with recommendations of no rest or no exercise or activity for about 2 weeks for those who were asymptomatic or mildly asymptomatic, and even longer convalescence and rest evaluations are required by the specialists for those who were sicker. And even recommendations by the European Association of Preventive Cardiology for a limitation of exercise and activity amongst athletes based on symptoms, and entailed recommendations on how to monitor athletes with troponin, EKG, echo, and CMR, and including an exercise tolerance test. And similarly, American Academy of Pediatrics provided guidance on exercise and sports and physical activity after COVID infection for children, recommending restriction from activity and exercise for about 3 to 6 months if the infection was severe, requiring ICU stay, for 14 days for mild or moderate infection, requiring further clearance and evaluation by a specialist. If we examine more detail what's happening to the heart, direct infection of the cardiac myocytes has not been the predominant feature to explain the extent of the myocardial injury. In the pre-COVID era, with other viruses, there is evidence of direct cellular injury with cardiotropic viral entry into the myocytes and subsequent innate immune response. With SARS-CoV-1, histological specimens reflected direct viral infection of the myocardium and the cells. The cardiotropic viruses such as SARS-CoV-1 should be typically cleared from the myocardium within 5 days. However, infrequently, the virus may persist in the myocardium for several weeks to months. SARS-CoV-2, we know, can enter the myocytes through ACE2 receptor, but we are now perplexed with the amount of injury and the discordance from the histology. The first case series, this is a case report, demonstrated clinically presentation suggestive of fulminant myocarditis. This was a first case report. Sudden onset, obvious symptoms of viral infection, rapid emergence of severe hemodynamic disorder, and global LV dysfunction, but a clinical diagnosis of myocarditis. And subsequently, we saw studies that there was evidence of the SARS-CoV-2 in the heart when the RNA copies were measured. And this is from autopsy series of patients who died from COVID. The levels were highest in the lung and pharynx, but the results indicated that SARS-CoV-2 was present in the heart, along with kidneys and brain and liver. Interestingly, however, in the autopsy and biopsy samples, the heart usually did not reflect fulminant myocarditis, as you see in the right lower panel. There are a few interstitial mononuclear inflammatory infiltrates, but no substantial damage in the heart tissue. Similarly, this is from another COVID-19 shock patient that required ECMO, where they biopsied, which reveals low-grade myocardial inflammation, and the ultrastructural EM images show cytopathic cardiac myocytes with membrane damage and cytoplasmic vacuoles, and evidence of coronavirus particles in the heart. But they were not able to localize it into the cardiac myocytes. These appear to be in the interstitium. The clinical presentation was definitely suggestive of severe myocarditis, but the pathology did not reveal fulminant lymphocytic myocarditis. So they thought maybe the localization in the heart could be due to an overspill during the viremic phase, or maybe from the lung itself. And the debate about whether the myocytes are fulminantly infected primarily by the virus itself or injured by the inflammation is still a debate. And in other autopsy series, this time from New Orleans, there was evidence of thrombi in pulmonary vessels and RV dilation. And this thrombosis and microangiopathy is seen across the whole continuum of the vessels, especially in the small vessels. But again, in this autopsy series, the myocardium did not show confluent areas of myocyte necrosis, only scattered individual myocyte necrosis with no lymphocytic myocarditis, suggesting that maybe the pericytes might be infected by the COVID-2. And maybe the capillary endothelial injury that is with the inflammation is causing the marked injury. So we're now facing changing paradigms and paths for our approach to cardiovascular disease with COVID. Regardless of the acuity of the presentation with the COVID-19 infection, our paradigm for all cardiovascular presentations include now testing for COVID. We in the US test all our inpatients for COVID. We test all our patients for pre-procedure for any cardiac procedure. So we now have an algorithm of those with COVID and those without COVID. And thus, it's clear that we now need to standardize our, not only COVID infection, whether it's acute, subacute, or chronic, and our ID colleagues are working on this, but also our definitions and presentations of cardiovascular entities with COVID that are all over the place with an overlap. And we need to probably standardize our terminology with an intent to see exactly how we're going to prognosticate and monitor. And of course, the underlying cardiovascular disease treatment is important. And with the new agents such as SGLT2 inhibitors or ARNI, the safety and efficacy, because I know these are being tried, of course, in the COVID patients, it's going to be very important for us to look at the spectrum of efficacy as well as safety. But more importantly, what to do about long-term cardiovascular complications, because we currently don't have a strategy. We need to collect data for the chronic complications from COVID. So in summary, COVID-19 is associated with a variety of cardiovascular abnormalities. Acute cardiac injury is prevalent in approximately a quarter to 1/3 of the patient. By imaging, by echocardiography, at least in the hospitalized patients, at least half of the patients have abnormality. Amongst recovered patients, more than 2/3 are able to be detected to have cardiac abnormalities. And even amongst athletes who have recovered by a single center study, there's evidence of some abnormalities in the myocardium. And the etiology of the cardiac injury is not clear, not appearing to be fulminant lymphocytic myocarditis. And further data are required into the mechanisms of whether it's the myocyte infection or is it just due to the inflammation. And the long terms require further data with imaging as well as biomarkers. And we need standardization on our terminology because I don't think the acute coronary syndrome myocarditis injury overlap with the thromboembolic and arterial embolic and endocellulitis concepts are going to be easy for us to communicate with each other and treat our patients. Thank you.
Dr. Bozkurt, thank you very much for this excellent presentation, for this overview about viral and this current pandemic. And then our next presentation is Dr. Mandeep Mehra, who is the head of the Heart and Vascular Center of the Brigham and Women's Hospital, and he's an expert about heart failure, heart transplant, and mechanical circulatory support, and he's the most indicated to this conference, past, present, and future of mechanical circulatory support. Dr. Mehra, thanks again, and for us, it's a real honor.
Dr. Gomez, thank you so much for the opportunity to present to you. I hope everyone that's listening and has taken time out tonight is safe and well, and your families as well. And I wish you all well. In the next 20 minutes, I'll give you an overview of where we have come in the field of mechanical circulatory support. And let me start by first reminding us that space travel and left ventricular assist systems have some commonality. And as we develop this talk, you'll understand exactly what that commonality is. For example, the first total artificial heart was implanted well before we had the first moon landing, believe it or not. And many people don't know this, that it was really in April of 1969 when Leota Cooley, the artificial heart was implanted in Dr. Bozkurt's area in Houston. And it was only in July that we actually landed on the moon. So both were great years. There was lots of ebullience, lots of enthusiasm. And we said, boy, we have a total artificial heart now, and we've reached the moon. There are no limits to human endeavors. And we have now done something that will be the most important future issue for healthcare in us. We'll now be immortal because we can now replace the heart. Well, it was not to be so. It turned out that just as there was a lot of challenge with space travel there was a lot of challenges with creating a viable total artificial heart, which really in the 70s led researchers to moving towards the paradigm of left ventricular assist systems. They decided that, look, if we cannot completely replace the heart, let us try to at least assist one of the ventricles, and that's where the generation of left ventricular assist devices in concept emerged. Now, this evolution has seen a flow from early generation pulsatile flow devices, and we somehow assumed that we needed to mimic the pulsatility of the heart. And what that did for us was that we ended up requiring very large and very bulky devices that then had to be implanted, and most often into the abdomen. And these really lacked durability. The biggest problem was they were not engineered for very long-term outcomes. It was not until we moved to continuous flow devices in the last few decades that this really turned into a therapeutic armamentarium for treating patients with advanced stages of heart failure. And we'll discuss some more about this and how this really came about. Because if you think about it, the very first trial of pulsatile flow devices, also known as the rematch trial, really was more of a proof. Do I say that? Well, it took a group of patients with advanced heart failure, and you can see the advanced heart failure patients in purple here had a treacherous course. So by 2 years, almost none of them were alive. Whereas with left ventricular assist devices, there was a clear improvement in outcome. And if you look at the median survival, there was a marked improvement in median survival of over 50%. But it was really only 8 months of meaningful survival, of which 3 months in these patients were spent in the hospital. So this did not really take off, largely because, as you'll see, by 3 years, even the device arm group had shown sufficient deaths where there was failure of durability of the device. So space travel comes back again, and this time it was really a NASA scientist, engineer, who was waiting for a heart transplant in Houston, who looked at his bulky device and said, you know, maybe you should learn something from rocket technology. And he turned to Dr. DeBakey in Houston and said, look, maybe you can actually decrease the profile of these devices if you change the way in which you think the circulation needs to be handled. And that was the emergence of continuous flow pumps, which are today's pumps, where you have either an axial flow pump or a centrifugal flow pump, and these actually result in low pulsatile circulations in the human body. Now, when you think about what this particular paradigm shift has done to survival, shown here is the classic rematch curves. And this is the first curve with the HeartMate 2 pump, the first continuous flow pump. And you can see there's a clear flattening of this curve, and the median survival now is extending to almost 4 years. And as we began to learn the application to better patient selection, we learned even more things. For example, we learned that there is such a thing as too late consideration for implants or too early a consideration for implants, and that there is something called a sweet spot with left ventricular assist devices and decision making, so that you should try not to be too late. And in fact, if you are too late and you take these crashing and burning patients and you try to implant these devices, the outcome is really not very good. So as we learned that, we also learned to take very good care of these patients. And with the same device, over time, as we selected patients better, as our management strategies got better, we actually saw an even greater improvement in survival with these second generation pumps. And most recently, the challenging part that emerged with these pumps was the onset of hemocompatibility-related adverse outcomes. And what are hemocompatibility-related adverse outcomes? These are different from biocompatibility. Hemocompatibility relates to outcomes that are encountered as the host interfaces with the device. And there are some very distinct patterns, and these cluster into 3 very unique effects that we notice. The first of which is the occurrence of de novo pump thrombosis. So these pumps, as they are continually pumping in a continuous manner, that there is a large incidence, somewhere between 6 to 13%, depending on the second generation device, of de novo pump thrombosis. They can, of course, ingest some clot, but they can also develop clot due to the heat and due to the destruction of red blood cells and the aggregation of fibrin within the device. The second big challenging part has been neurologic complications, and these have really been the bane of our existence until recently with the generation of newer devices that we'll discuss in a moment. And these have been linked mostly to blood pressure management as well as to the adequacy of anticoagulation. They also relate to the mechanical features of the device and how an outflow graft is inserted or placed in the aorta, but more on that later. Perhaps the most vivid finding in hemocompatibility-related outcomes is the development of gastrointestinal bleeding, which really is associated with arteriovenous malformations. And this is really on the backbone of the development of an acquired von Willebrand factor deficiency that occurs due to shearing of high molecular weight multimers of von Willebrand factor as a result of this high stress circulation and increased residence time in the high oxidative stress circulation. And this has been really a challenging issue for us, which has led to an interwoven clinical course of a dynamic equation where you have either bleeding, in which case we then pull back anticoagulation, and then it tilts the spectrum towards thrombosis. Or if you have a lot of thrombosis, then we give more anticoagulation, which tilts it towards bleeding. This has been the main challenge with the second generation devices. And several studies have been done, which I'll share with you. The endurance study, which compared the HeartMate 2 to the hardware HVAD pump in transplant ineligible patients, was performed. This had a population that was in the late 60s, if you will. And this particular study showed non-inferiority of these two pumps on the primary endpoint of survival free of a disabling stroke over 24 months, or the need to exchange or replace the device. Now, when you look very carefully at the hemocompatibility-related data of adverse outcomes in these studies, you find that the incidence of gastrointestinal bleeding was quite significant with these pumps. What was even more striking was that one of the pumps, the hardware HVAD pump, had 3 times the stroke risk as the HeartMate 2 pump, whereas the HeartMate 2 pump had about 2-fold higher risk of de novo pump thrombosis, saying that neither of these two pumps were at a stage of hemocompatibility-related adverse events that were well supported. So these strokes that we also see, are they just simply because of the unnatural physiology? I don't think so. We actually used to see the same number of strokes even with the first generation pulsatile flow pumps. The only difference is that we now see more ischemic strokes, and in those days we saw more bleeding related strokes, but we saw strokes even with first generation pumps. And in fact, a trial was done, which was a follow-up of the endurance trial, because the HVAD study group had seen such a high incidence of stroke rates, 3-fold higher stroke rates. This trial was done where in the randomized group of patients to the HVAD, they lowered blood pressure down to a mean arterial pressure of 85 millimeters of mercury or lower. And in those patients, they also maintained their aspirin and their anticoagulation at fully therapeutic levels. And they looked to see if that made a difference. Unfortunately, it did lower the risk of hemorrhagic strokes, but this trial did not meet its non-inferiority endpoint, suggesting that the stroke rate with the HVAD hardware device is clearly higher than the HeartMate 2, even when anticoagulation and blood pressure is attended to. However, you can lower the risk of hemorrhagic strokes as a result of meticulous attention to blood pressure with the hardware HVAC. Suffice it to say that this led engineers to try and create a new pump, and a newer device called the HeartMate 3 pump has been now introduced. It's a centrifugal flow pump, which is engineered to minimize red cell destruction and really try and obviate one of the key hemocompatibility-related adverse events, which is essentially the issue of de novo pump thrombosis. Now, this particular pump has three features. The first is that it has wider blood flow pathways that reduce shear stress. The second is that it's a fully magnetically levitated platform, which allows for the function of the rotor to be completely frictionless. And the third is that this pump is not just a pure continuous flow pump, but is in fact the first hybrid pump that allows for a degree of pulsatility. Now, this pulsatility, which is a fixed pulse algorithm, was designed to prevent stasis within the device, but this particular intrinsic pulsatility also in some cases confers at least a weak peripheral pulse, which allows you to even measure automatic blood pressures rather than relying purely on Doppler-based assessments to measure blood pressures in these patients. Now, with the Momentum 3 trial, which was the trial that tested the HeartMate 2 compared to the HeartMate 3, a one-to-one comparison, there was evidence that at least at 2 years, that the outcomes have improved and that these outcomes are now approaching the 2-year outcomes that we see with heart transplantation in patients, in over 80% 2-year survival. However, the journey of these patients out with hemocompatibility-related adverse events has clearly gotten better, but that combined with risk of infection from the driveline and from other aspects is still not at the point where it allows for a direct comparison to heart transplantation. Now, the Momentum 3 trial was a 3-phase trial. It was published sequentially in the New England Journal of Medicine. Each of these trials, the first was a short-term trial, the second was a long-term evaluation of the trial, and the third was a full final cohort, which represents the largest LVAD trial done, with over 1,000 patients randomized to either the HeartMate 2 or the HeartMate 3. And I'll share with you the final outcomes, which were reported about a year ago. And this particular trial, the first of the trial powered analyses, which was at 6 months, clearly showed that there was a marked elimination of pump thrombosis with the new pump. And this was driven into superiority of the pump in that sense. Out to 2 years, this finding was maintained. And in fact, another observation made was the lower incidence of stroke rates with the HeartMate 3 with the longer term follow-up, suggesting that there was a marked reduction in stroke rates. And then in the final analysis of the 1,000+ patients that we analyzed, it became quite clear to us that not only was there near elimination of the pump thrombosis risk, but there was halving of the strokes, and there was even a third reduction in non-surgical bleeding, including gastrointestinal bleeding. And there was a consequent reduction in hospitalizations as well as in ventricular arrhythmias and other cardiac arrhythmias with this pump, suggesting that clearly the journey of these patients is better on this pump, and it may be a bit more cost effective than the HeartMate 2, may not be cost effective in terms of society yet. The other important finding from this particular study was that whether you intend to use the pump for bridge to transplantation or for lifetime therapy as destination therapy, that at least with the HeartMate 3 pump, that the overall survival at 2 years appears to not be different by category. And this is very important, which has now led the CMS or Medicare in the United States to issue a national coverage decision that is under a comment period to do away with these artificial categories and allow clinicians to address these categories as they see fit, rather than create reimbursement challenges to clinicians. Now, in the last 5 minutes or so with you, I'd like to discuss an important notion of myocardial recovery. And we have always thought that perhaps if we implant an LVAD, we will see a lot of myocardial recovery, enough to the point that we can explant these hearts. But the data has not been in that direction. And part of the question that arises is, does the recovered heart, even though you unload the left ventricle, does it somehow retain its phenotypic deformation memory? And that's true, because when you look at cellular features of reverse remodeling in patients who are unloaded on the left ventricle, turns out that only 5% of dysregulated genes actually revert to normal after the LVAD implantation. The other intriguing finding is that when you look at the scaffolding of the heart, or the extracellular matrix, does not revert to normal on its own and can actually exhibit increased myocardial fibrosis. So it can go in any direction. And of course, I think that the reason why this is so is that the pathophysiologic signals of failure continue to persist in the unsupported ventricle. And in fact, when you place an LVAD, you actually deform the right ventricle in a way that you create right ventricular dysfunction. And in fact, I believe that it is this ventricle that retains the phenotypic memory, because when you create a suction force, you create mechanical dyssynchrony of the septum, you create actually dilation of the RV because of an increased preload, and you may in fact even change the coaptation point of the tricuspid leaflet that alters tricuspid regurgitation in these patients. So there are many reasons why recovery is not seen as commonly as we would anticipate with unloading. And in fact, this has recently been tested, and if Dr. Boskart is still on and listening to us, Circulation, which is a journal that Dr. Boskart serves as a senior associate editor of, just recently published this trial, the Restage Trial. This was a trial designed to look at non-ischemic patients with less than 5 years of heart failure, less than 60 years of age. This group, in an uncontrolled manner, enrolled 40 patients. And this particular trial has kept the concept of recovery a bit alive, but it's barely breathing, in my opinion, in highly selected patients. And why that is that this turned out that these 6 centers that took several years to recruit 40 patients included a highly enriched population. About 37.5% by intent to treat of the population by 2 years was able to be explanted and remain in remission. And the main question with this trial is, how representative is this population? If you look at the data carefully, the average age of the patients was in their 30s, and the average age in heart failure was just over 1 year. And so this is not a very generalizable population, but clearly the concept is alive that for a few patients, you can consider explantation of the device. The final thing that I'll share with you is, some have argued that maybe the reason why you're not seeing recovery is you're not bolstering the heart with stem cells. And a trial that looked at mesenchymal stem cell implantation during LVADs, a randomized controlled trial that had a surrogate endpoint at 6 months, suggested that after bolstering the heart, that there was absolutely no facilitation of left ventricular remodeling in excess of what one would note just from unloading alone. And so this too has really cast a doubtful shadow on myocardial recovery, and therefore has led to the notion that we see some remission but not necessarily recovery. And even those where we do see recovery are generally those patients who see recovery of their right ventricle and who are destined to have that. So let me end my discussion with you by reminding us all of a quote by Stephen Hawking, who was a great scientist and lived his life with ALS in a wheelchair, yet contributed a lot. And he said, however bad life may seem, where there is life, there is always hope. Thank you so very much for your attention today.
Doctor, thank you very much for this interesting journey. We hope we're going to enjoy at the end the questions that you may include in the chat. And then we have finally the honor to have Dr. McMurray, who's joining us from UK. I know it's very late in UK, and he has been very patient to share with us two consecutive talks, and at the end we're gonna have a brief space for questions. Dr. McMurray, again for us in Cali, Colombia, in Latin America, and all the participants, it's an honor to have you here, sharing your knowledge about heart failure.
Thank you very much, and good evening. I hope you can hear me okay. Thank you for inviting me to speak at your Congress. I'm delighted to help. So the first of my two presentations is about sodium glucose cotransporter 2 inhibitors, or SGLT2 inhibitors. These are my disclosures. So I think most people know about SGLT2 inhibitors by now. These were drugs that were actually introduced many years ago as a treatment for type 2 diabetes. These drugs lower blood glucose by increasing urinary excretion of glucose, and they do that by inhibiting reabsorption of filtered glucose in the proximal renal tubule. That is what the type 2 of the sodium glucose cotransporter family does, and we believe that this is only located in the proximal renal tubule. But the story in relation to heart failure in these drugs started back in 2015, and that story started because the US Food and Drug Administration had mandated that all new glucose-lowering therapies had to demonstrate cardiovascular safety. So a series of trials were set up using this new family of drugs in patients with type 2 diabetes. And in the first of these trials, called EMPA-REG Outcome, empagliflozin was compared to placebo in patients with type 2 diabetes who also had cardiovascular disease. Now, that was mainly atherothrombotic disease, in other words, coronary heart disease, cerebrovascular disease, peripheral arterial disease. Most patients with type 2 diabetes in this trial did not have heart failure. But one of the striking findings in this study was this 35% reduction in heart failure hospitalization. Very few people had anticipated that this finding would occur, and most people were very surprised by the rapid onset of benefit you can see here with this early separation of the Kaplan-Meier curves, suggesting that this could not be a benefit explained by glucose lowering. So back in 2015, we had evidence that these drugs could sort of prevent the development of heart failure, and the next step was to establish whether SGLT2 inhibitors would be beneficial in treating patients with established heart failure. And we had two additional questions really to think about when we were designing the first trial to test this question. The one question was whether we should study only patients with type 2 diabetes, or should we study all patients with heart failure? If this wasn't about glucose lowering, then we could actually test these drugs in all comers with heart failure. And of course, the second big question was, should we study this type of treatment in HFrEF or in HFpEF, or maybe in both types of heart failure? Well, we decided that we would study this treatment in HFrEF, and about a year ago, we presented the results of our trial, which was the DAPA-HF trial. And this was a comparison of dapagliflozin to placebo, as I said, in patients with HFrEF, but very importantly, patients with HFrEF with or without type 2 diabetes. This was the first SGLT2 inhibitor trial that included patients who did not have type 2 diabetes. In fact, 55% of our patients did not have type 2 diabetes. This was a large global study. In fact, Latin America was a very large contributor to DAPA-HF. The patients were typical of those with heart failure and reduced ejection fraction, and we included patients with an eGFR as low as 30 mils per minute. The primary endpoint was a composite of cardiovascular death or worsening heart failure, and as you can see, there was a relative risk reduction in this primary endpoint of 26%. It was a statistically significant benefit. The absolute risk reduction was also large, here shown as a number needed to treat of only 21 patients over a median of about 18 months to prevent one patient experiencing the composite outcome. And as you can see here, again, early separation of the Kaplan-Meier curves. In fact, these curves were statistically significantly different within less than 30 days of starting treatment. And when you look at a composite endpoint, you should always look at its components. And you can see that both the worsening heart failure event component, which by the way was principally heart failure hospitalization, this was reduced significantly, as was the cardiovascular death component. And indeed, when we looked at the other composite endpoints we said we would look at, even when we looked at all-cause mortality, you can see that there was a very consistent benefit of dapagliflozin, and all of these hospitalization and mortality endpoints were reduced significantly with dapagliflozin added to what was best conventional therapy at the time. Now, of course, everybody wants to know, was this benefit just confined to the 45% of patients who had diabetes at baseline, or in fact, did we also see benefits in the 55% of patients who did not have type 2 diabetes at baseline? And you can see from this slide that the benefit was entirely consistent whether patients had diabetes or did not have type 2 diabetes at baseline. You can see that there was about a 25 to 27% relative risk reduction. And indeed, in further analysis, we were able to show that dapagliflozin was beneficial in patients with HFrEF with a completely normal glycated hemoglobin. So we did look at some other endpoints, and one that I want to particularly mention is symptoms, because of course, one of our goals of treating heart failure is to make people feel better, or if we can't make them feel better, certainly to try and stop their symptoms deteriorating over time, as they tend to do in this progressive disease. And we did look at symptoms. We measured symptoms using the Kansas City Cardiomyopathy Questionnaire. And here you can see the proportion of patients in each of the two treatment groups who between baseline and 8 months after randomization had a clinically important deterioration in symptoms. That's a 5 or greater point decrease in the KCCQ total symptom score, or who had a clinically important improvement in symptoms. That's a 5 or greater point increase in KCCQ score. And you can see that patients randomized to dapagliflozin, shown in blue here, were significantly less likely to have symptom deterioration, significantly more likely to have symptom improvement. And what we saw in this trial, which we've really not seen in previous studies, was not only was there a 5 or greater point improvement, but we saw these much larger improvements in symptoms that were also significantly more likely with dapagliflozin than placebo. Now, I'll just mention one or two additional findings that we've published in relation to subgroups and other outcomes over the past year. So here was the classical forest plot that we always report in the primary results paper, and you can see that across all the subgroups that we looked at, there was a very consistent benefit of dapagliflozin. But we have delved into each of these subgroups in more detail, and I will pick out one or two I think are particularly important. One of those is looking at the effect of treatment by age, and here you see the primary outcome. The green line shows you a continuous hazard ratio for the effect of treatment with dapagliflozin compared to placebo. So if the hazard ratio is below 1, shown here by the red horizontal line, this indicates benefit of dapagliflozin. And the x-axis in this panel shows you age from 40 years approximately right the way up to 90 years. Our oldest patient was 94 years of age in the trial. And you can see that right across the spectrum of age in this study, there was an entirely consistent benefit of dapagliflozin. And what was also really striking in this trial was that dapagliflozin was as well tolerated, essentially as placebo, even in elderly individuals. So this treatment was both well tolerated and effective right across the spectrum of age, including in older individuals. Of course, one of the other questions that we've frequently been asked is an SGLT2 inhibitor beneficial on top of all the other effective therapies we have for heart failure? And we've published about this in detail. So here you can see some of those commonly used treatments: diuretics, mineralocorticoid receptor antagonists, principally spironolactone, digoxin, sacubitril, valsartan, which I'll come back to, ivabradine. And again, you can see that essentially the treatment effect here is the same. All the hazard ratios are pretty similar. There's no interaction between these therapies and the benefit of dapagliflozin. And in this paper, we've actually looked at many more treatment subgroups, including patients in larger doses and combinations of these drugs. Also looked at patients with various cardiac devices. But the simple message is the benefit of dapagliflozin is very consistent with the overall benefit that we saw in the overall trial population. So that's, of course, a lot about efficacy. Now, I mentioned that the safety, even in elderly patients, was essentially similar to placebo, and here's the evidence for that. We had a number of pre-specified adverse events that we said that we would look at. For example, volume depletion, meaning hypotension, dehydration, dizziness, syncope, renal adverse events, then some diabetes-related adverse events. But what you can see is that if you look at the two treatment columns here, none of these adverse events were particularly common. So the most common was volume depletion. That occurred in about 7% of patients randomly assigned to placebo, and it occurred in a similar proportion of patients randomly assigned to dapagliflozin. And none of the other adverse events were common, and none of them were significantly more common in patients randomly assigned to dapagliflozin. In particular, hypoglycemia was not more common. There were 3 cases of ketoacidosis. They only occurred in patients with type 2 diabetes, and in this trial, they were all in the dapagliflozin group, but that is 3 cases out of 2,300 patients. I can't go through all the other detailed follow-up information we've written about in this trial, but if you are interested, we've now got many papers published, at least online, and I believe they are all freely accessible if you're interested in reading these. So just to put the DAPA-HF trial in some context, here is our last big breakthrough, the Paradigm Heart Failure trial. Here is the effect of sacubitril valsartan compared to enalapril on the commonly reported morbidity, mortality endpoints, either composites or individual components, or indeed all-cause mortality. And you can see that compared to sacubitril valsartan, the benefits of dapagliflozin really are at least as large. Now, I'm going to come back in a moment to really emphasize the point that these are not competing therapies. These benefits, these large benefits with the individual treatments are in fact additive, and I'll show you the evidence for that in a moment. But very importantly, recently, we've got strong supportive information confirming the benefits of dapagliflozin and DAPA-HF using a different SGLT2 inhibitor in a second large trial. That second large trial is called Emperor Reduced. It was presented at this year's European Society of Cardiology Congress, published simultaneously in the New England Journal of Medicine. The primary endpoint in Emperor Reduced was essentially the same as the primary endpoint in DAPA-HF. And as you can see here, the results were almost identical. You could really not get two more similar results. So this is very strong supporting evidence. And in fact, here are the two trials set out side by side with exactly the same endpoints shown in each row. And here you can see the hazard ratios or rate ratios in the two trials. And you can see that by and large, they're really very similar. There was some difference in mortality, but Emperor Reduced was a smaller study with fewer deaths. It didn't really have the statistical power to show a clear effect on mortality. But if you put the two trials together in a meta-analysis, as Fayez Zinad and colleagues did in the Lancet, you can see that clearly SGLT2 inhibitors reduce mortality. And they do more than the things that I've mentioned. They also slow the rate of decline in eGFR over time. We've published this recently in Circulation from DAPA-HF. It's also been published from Emperor Reduced. The slow decline in eGFR over time that we all know is a major problem in our patients with HFrEF is significantly reduced by SGLT2 inhibitors. And in fact, we saw that this was the case even in patients without type 2 diabetes. And then we've just recently presented, and this paper is now in press, our findings in the patients in DAPA-HF who did not have type 2 diabetes at baseline. In those patients who didn't have diabetes, we examined the incidence of new onset diabetes during follow-up in the trial. And you can see that compared to placebo, dapagliflozin reduced the risk of new onset diabetes by 32%. I would say a very important additional benefit of these drugs. So clearly, SGLT2 inhibitors are a very, very important new treatment for patients with heart failure and reduced ejection fraction, not just reducing hospitalization, not just reducing deaths, also improving symptoms, also preventing or slowing the rate of decline in kidney function, and as I've just shown you, at least in DAPA-HF, also reducing the risk of new onset diabetes. But what is most important is that those benefits were obtained on top of best conventional therapy, including sacubitril valsartan. So in 2020, we live in a very interesting time for the management of heart failure and reduced ejection fraction. We entered this century with evidence that 3 drugs used in combination could make a huge difference to our patients with heart failure. In other words, a RAS blocker, a beta blocker, and an MRA. over the past 20 years, we've seen 4 more drugs demonstrate benefit on top of these 3 therapies. But I'm going to focus on just these 2 because, of course, these are the 2 that reduce mortality. Ivabradine in SHIFT and recently vericiguat in the Victoria trial did reduce heart failure hospitalization. Worthwhile benefit for sure, but I think we place more emphasis on drugs that also reduce the risk of death. So as we enter the final part of this year and the beginning of a new decade of therapeutics, I think we will be talking about the 5 alive, the 5 pharmacological interventions that improve survival. Each of these works through a distinct pathophysiological pathway. We believe each of them has an additive benefit. Of course, we can give these 5 different pharmacological interventions in 4 pills because sacubitril valsartan, of course, contains 2 of these therapeutic interventions. Now, many people ask, are we really justified in using all of these drugs? Do we really have to do that? And of course, that question today is principally about whether we have to use an SGLT2 inhibitor and sacubitril valsartan together. And the answer is clearly yes, because if you look at the subgroup in DAPA-HF who were receiving sacubitril valsartan at baseline, they had exactly the same relative risk reduction as the patients not receiving sacubitril valsartan, 25% relative risk reduction compared to 26% relative risk reduction. In other words, dapagliflozin was having additional benefit over and above the benefit we already know these patients were getting from sacubitril valsartan. But more importantly, the Emperor-reduced trial, which had a larger subgroup of patients receiving sacubitril valsartan at baseline, confirmed this. And in fact, remarkably, in this subgroup, showed, as you can see here, within subgroup statistical significance. You don't often see that. Usually we rely on an interaction p-value to show no interaction between the background treatment of interest and the experimental drug. But here you can see that there was a significant benefit of empagliflozin on top of sacubitril valsartan. So these drugs have added benefit, and the benefit that you get from using sacubitril valsartan and dapagliflozin on top of conventional therapy together is enormous. So here is, for example, what you would expect to see in terms of reducing the risk of heart failure hospitalization or cardiovascular death, a 40% relative risk reduction from using an SGLT2 inhibitor, an neprilysin inhibitor, on top of a background of RAS blockade, beta blockade, and a mineralocorticoid receptor antagonist. And very importantly, it is possible to use these 2 treatments together safely. They are well tolerated when they're used in combination. I haven't got time to go into the details of that, but in this paper, which is available in the current issue of JACC Heart Failure, we describe in detail the adverse event profile, the effects on blood pressure, renal function, and potassium of using an SGLT2 inhibitor along with sacubitril valsartan. And you will see if you read this paper that the 2 drugs can be used together without any major problems in relation to adverse effects. Now, maybe some of you are saying, this is too complicated, too many drugs, why do we have to use 4 different therapies? But I would just point out that this is something that it's probably only heart failure doctors say to each other. Oncologists don't complain about using combination therapy in cancer. our interventional colleagues use multiple drugs quite routinely to antiplatelet therapies, beta blocker, statin, and ACE inhibitor after a primary coronary intervention for acute myocardial infarction. And of course, combination therapy is standard in hypertension and type 2 diabetes. So we shouldn't make excuses for not using these therapies. We really have to use these treatments. They have a really important long-term meaningful benefit. We've just published recently a paper in The Lancet trying to quantify that benefit. And what this figure shows is the years of event-free survival gained, or the years of overall survival gained, if you use those 4 tablets together, if you use these 5 different pharmacological interventions together, compared to using the most basic treatment for heart failure, just a RAS blocker and a beta blocker. If you use comprehensive therapy compared to conventional therapy, for example, in a 65-year-old patient, you can expect to gain perhaps 7 years of additional event-free survival. That means survival free of hospital admission with worsening heart failure or cardiovascular death. You can expect to obtain 5 additional years of life. That is a huge incremental benefit in overall survival. I think we have to rethink about how we do this. And I do believe our guideline committees will have to reconsider our traditional approach. Most of our guidelines show this sort of vertical stepwise algorithm where we start with one drug, we titrate to the full dose of that drug, we proceed to add the second, and so on and so forth. And the order in which these drugs are added is based on the chronology of our clinical trials. But this really doesn't make sense because, as I've pointed out, these drugs all work in different ways. What we should be trying to do is preserve organ function to keep our patients alive and well, to stop their disease progressing. And each of these drugs, as I said, works in a different way. And really the goal of therapy in the future has to be to implement as many of these drugs as quickly as possible. They're all working in different ways. Their benefits are additive. And in fact, their benefits are often observed very rapidly after initiation of therapy. And I want to really finish by trying to make a plea to think about time, to think about the speed with which our patients deserve to be treated. And as part of thinking about that, also think about the drugs that we use and the ease and speed of up titration of these therapies. Because some of our treatments, we are really spending a lot of time starting them and up titrating them. In fact, for some of them, if we really followed the guidelines as they're currently written, taking 2 to 4 weeks to go through each dose step, it could take up to 16 weeks to reach the target dose of some of these treatments. And that really makes no sense because, for example, with sacubitril valsartan, we saw a statistically significant benefit within 30 days. As I said, for DAPA-HF, there was a statistically significant benefit of SGLT2 inhibition within 28 days. So these treatments are working quickly and we need to get them started quickly. And again, it's always puzzled me as why in most healthcare systems, cancer is considered an urgent condition in terms of diagnosis, urgent in terms of treatment, but we manage patients who have a survival that is often worse than many common forms of cancer. But I don't have a sense of the same urgency when it comes to treating our patients with heart failure. And we have to think about why that is. why are we not acting quicker? Why are we not doing more for our patients? And I think the problem is this is a normal human condition. I suffer from it as much as anybody else. Inertia, it really is the tendency for us really not to do things unless we have to. And I think you often hear clinical inertia expressed by your colleagues. You may have even said some of these things yourself. Our patients don't have mild heart failure. There's no such thing as mild heart failure. Just like you would never describe somebody as having mild breast cancer or mild colon cancer, you should not talk about mild heart failure. Our patients are not stable, far from it. As those Kaplan-Meier curves have shown you from the different trials tell us, that even patients with mild symptoms on very good treatment progress very rapidly. Why should I change anything? It's inconvenient for the patient. Well, it's not really. And if you decide that you'll wait to see and only act if the patient deteriorates, you'll miss the opportunity, because the first manifestation of worsening, the first manifestation of deterioration may be sudden death, and you may never see that patient again. So I'll finish with this slide, which is a friend of mine told me this is a poster that is in one of his children's bedrooms, and this is really to remind his child about tidying up their bedroom, but we could use the same approach when we think about therapy. And the question here is, are we going to decide to act quickly to use these effective treatments that we now have someday, one day in the future? Or are we going to act on day one? Are we going to do it immediately? Thank you very much.